harm happening. There is none of the crab criteria or even the slim crab criteria. It is reasonable to wait. We have seen in studies treating early when there is no damage happening to the body does not necessarily lead to better outcomes. If a person is feeling great and you give them myeloma treatments, chances are they will not feel great. So you have to make that balance. Is the treatment necessary? And the second question we want to answer, or at least address right in the beginning, is transplant an option? And what I mean by that is the person likely to be a candidate for transplant? If a person has several other health problems or had some other bone marrow issues, they may not be a candidate for transplant, then we think about the treatment plan for them a little bit different. And once those questions have been answered, we look at these factors.
With the bone marrow. When someone has myeloma, this bone marrow gets damaged. Sometimes those myeloma cells can break through the bone and cause bone damage, cause those lytic lesions. Other times, the infrastructure becomes so damaged that the bones kind of collapse or crumble. There was a question that has been asked a couple of times, well, did you have bone pain or not? And Tim said he did not, because we know that there are subtypes of myeloma based on genetics which do not cause bone damage. But there are other subtypes which will cause more kidney damage, etc. So when there is a healthy bone marrow, it has some plasma cells. All of us have plasma cells. But when there is damaged bone marrow, there are too many of these plasma cells which are damaged, so are producing the abnormal antibodies. For some reason, these plasma cells are always given the term of a fried egg appearance. By the way, I think egg appearance, etc., etc. Okay, so there are lots of risk factors for myeloma: age, gender, family history. We talked about that. Prior history of MGUS, exposure to certain chemicals, race. We know African Americans are twice more likely to have myeloma than whites. 9/11 exposure has been very clearly shown to be associated, and there is also other exposure, like for example Agent Orange. Agent Orange exposure from Vietnam War, etc., has been linked with myeloma. So lots of things. We don't have the one cause that we can change and then suddenly say, hey, now you're not going to have myeloma. That we cannot. But there are lots of things that contribute to it. Patients, because they have the bone marrow getting filled up with the myeloma cells, these abnormal damaged plasma cells, that's why they would have low blood counts. Low blood counts could tend to cause weakness, fatigue, or infections. They would have decreased kidney function because all those extra proteins that are being made, they are circulating through the blood, getting filtered through the kidneys, depositing in the kidneys, and damage the kidney membrane. So a lot of this protein also spills out into the urine. So that's a very common symptom. About 20% of myeloma patients will present with significant kidney damage at the time of onset. Not everybody does that, but in a lot of patients that happens. Bone damage, again commonly seen because when plasma cells grow, so in our body there's a balance of two kinds of bone cells. Osteoblasts, which deposit bone, and osteoclasts, which resorb bone. All of us have this. That's how bones get remodeled after fracture or just as we age. In myeloma, the osteoclasts, or the cells that are resorbing the bone, are hyperactive or overactive, and the osteoblasts, which are depositing the bone, are turned off. And that's why there's this disbalance, and the bones can get damaged and these lytic lesions come up. That's where the bone turnover increases. But it's also important to note that about close to a fifth of patients with myeloma may not have any symptoms at the time of diagnosis. And as I'll share, we've actually lowered the bar for myeloma in the sense, in 2014, the definition got changed. So patients who would previously, a subgroup of patients who would have smoldering myeloma are now defined to have myeloma. Oh, sorry, wrong button. Okay, so as I said, myeloma, it's always preceded by MGUS. MGUS always changes to smoldering and then to active. Not everybody gets caught in the MGUS area, not everybody gets caught in the smoldering area, but that progression happens. The risk of myeloma is different from MGUS as compared to from smoldering. As I said, these proteins that are present in everybody has the heavy chain and the light chain. How these heavy and light chain components are combined together decides whether it is IgG myeloma, IgA myeloma, IgM myeloma, D or E myeloma, or light chain only myeloma, or heavy chain only myeloma. When these Y-shaped structures are connected in the middle and there's a dimer or a combination of two of them together, that's IgA. IgG is a single Y molecule, IgM is a pentamer. So how they are, and this is basically going back to what that one plasma cell that became cancerous, what that was destined to make. If the plasma cell that became cancerous was destined to make IgA type protein, that person will have an IgA myeloma, or IgM, or IgG, or light chain only, etc. Okay, so it's talking about some basics. What is this protein electrophoresis? We've already talked about the M spike and where it is, etc. So what is what does this mean? So the protein electrophoresis is basically your blood sample is taken, it is spun around, the cells are discarded, the liquid part, which is the serum, that is taken, which has the protein, that is put on an electrophoresis membrane, or just a membrane, and electric current is passed through it. Based on the electric current, the proteins separate out on that membrane, or the gel, based on their weight. So in a healthy individual, everybody, we have, the peak is what's called albumin, that is the normal, and then there is alpha-1 globulin, alpha-2 globulin, beta globulin, and gamma globulin. Present in everybody, all of us have these proteins. But in the setting of myeloma, what happens is that this gamma globulin is where the abnormal protein shows up. And the S-spec, or the M spike, tells us the quantity. So for example, Tim mentioned this morning that his S-spec has shown that M spike of 0.3 or 0.4, and it is kind of there. That is his M protein, or the abnormal protein. So those abnormal cells are still there, but they're being kept quiet. So the S-spec is telling us how much is the abnormal protein. And then there is a test called immunofixation. Now at Mayo, we have the convenience because we don't have to order the immunofixation separately. We do the S-spec. If the M spike is there, the lab takes care of the immunofixation. And even beyond that, the lab comes back and tells us, hey, this is the same M spike that was present before. In some labs in the community, and I'm not saying they're doing it wrong, they have a business model, they have figured out what's the most cost-effective way of running tests, because S-spec is not the only thing they do. They will do the S-spec, and if there is an M spike, sometimes they will say, well, an immunofixation would be helpful, but it is up to the physician to request it or not. So I think those are things that affect us when we are evaluating those results from patients who are getting their labs done elsewhere. There is a difference, and we have a model of working at Mayo, LabCorp may have a model, et cetera, et cetera. But it's important for a patient to understand what these things mean. The immunofixation is telling us what is that protein that was picked up by the S-spec. And that immunofixation, for example, here, there is an IgG kappa band. Over here, there's an IgM kappa. Over here, there are two. There's an IgA and IgG and IgA heavy chain, and there is a lambda light chain, which means there is an IgG lambda and an IgA, small IgA lambda. Two different proteins are coexisting. It is the lab's job to separate out the values and tell us about it. And over here, there is probably a very small kappa light chain that is most prominent. So this is how we find out what is the disease, how much of it is present, and what is that abnormal protein. But then obviously, our most favorite, and I think it's not showing it very correctly, but the light chains. So I've shared before with some patients, whenever math comes, doctors are not the best. So whenever there are some mathematical calculations, things get confusing. Part of it is because when we use the terms ratio and numbers and kappa and lambda. It kind of sounds intelligent, right? So this is the same model with another disease like CML, chronic myeloid leukemia, where there are PCRs and percentages, and et cetera, and things can sometimes get confusing. Same for myeloma. So it's important to know, I'm sorry, like I said, it's not showing up correctly, but the units of what the light chains are. At Mayo, we use milligram per deciliter. Outside, the rest of the world uses milligram per liter. And the only reason is because we have to be different. So just kind of bring in that layer of kind of extra discussion. But it's also important to know that this ratio that everybody talks about, it is important. For example, if the kappa and the lambda are normal, let's say, and the ratio is this. If kappa was increased and lambda was where it was, let's say the ratio is 100. Next month, the patient gets labs checked again. Kappa is their diseased light chain. That stays the same. But the lambda changes from 1 to 0.5, and suddenly the ratio is 200. If I say, oh, your ratio has doubled, we got to do something about it, but a patient may come and say, are you serious? My lambda dropped from 1 to 0.5. That's the only change that happened. And I feel the same. Suddenly I need treatment. So this is an important discussion point with the physician. I saw a patient 2 days ago, and I'm thinking he might be here. Haven't run into him yet. He's going through this right now. He had a transplant 10 years ago. And now his disease seems to be growing very slowly. And I've told him, I said, you know what, in my mind, you're back, and he's not on any treatment right now, because when he got his transplant, maintenance was not the norm. So he got 10 years out of the transplant, and at this point, I've told him, I think you're smoldering myeloma all over again. So I'm going to apply the same rules that I applied to smoldering myeloma, and we're going to use those to decide when you need treatment. But for 2 months in a row, his light chain ratio was above 100, and then now 3 months in a row, his light chain ratio has been below 100. So I think it's important to individualize that treatment. It is important to figure out that one size may not fit all. And we know that kidney function affects light chain numbers, because kidney function worsening, that's what is affecting the light chains also. But if somebody's kidneys are abnormal, then generally both of them are increased and the ratio tends to stay the same. Okay, bone marrow biopsy. Unfortunately, it is necessary. Nobody likes it. We offer sedation, but sedation marrows are not so easy to get because they're only done once a week, half a day. I know it's a pain in the butt, but we got it. And the problem is because there are studies that have been shown at ASH recently, this American Society of Hematology meeting. Unfortunately, we are not to the point that a blood test matches up with the bone marrow. In certain kinds of leukemia, it's possible, but unfortunately in myeloma, that has not been proven yet. But at least stay tuned, because those works are being done. And when we do clinical trials and we throw in extra bone marrow biopsies or ask you for extra ones, I think you're asking the right question. Hey, if I go on study, how many extra marrows do I have to do? That's an excellent question. And if you do not get a good justification for us, fine, say no to the study. But if you feel that there is a justification, consider that, because we'll be able to learn so much more about the disease. Unfortunately, that's the only way of doing it. But hopefully that'll change. It also tells us the genomic profile of the myeloma cells, and that helps sometimes pick the right treatment. Okay, I mentioned that there is a continuum from MGUS to smoldering to myeloma. What I'll quickly say is that we always talk about these CRAB symptoms: calcium, renal or kidney, anemia, and bone. Whenever somebody has a calcium problem, increased calcium, kidney dysfunction, anemia, or bone disease, we say that they have transitioned from smoldering to active. But as I said, in 2015, we lowered, or 2014, later part of 2014, we lowered the bar. Because this CRAB, what we realized that was that if this is MGUS and there is a steady, slow increase to myeloma, risk of increase to myeloma, in smoldering, the curve is a little bit different. There is this group of patients who has a very high risk of progression, and this group which has a very slow, gradual risk of progression to myeloma. So the thought was, okay, can we figure out who are these patients who have a high risk of progression, because now we have much better drugs? Why let them have a bone lesion or kidney failure and then treat it? Why not try to treat them timely? So that's why the crab was changed to the slim crab, which has 60% bone involvement, marrow involvement, light chain ratio above 100, and an MRI lesion if it is present, and these three were added to the crab. If a patient has any one of these, we treat him. Okay, the bone marrow biopsy also tells us the risk stratification. Every patient should know what their risk stratification is. Are they high risk or standard risk? We can go into details, but there are some mutations. If present, they make it high-risk disease. And then the treatment and the outcomes are a little bit different. Okay, so some general principles about management. We prefer 3-drug regimens. There are many, many studies that have shown that typically 3-drug regimens are better. Longer duration of therapy is preferred. We try not to stop treatment. You will have success stories, like I said, the patient from Thursday who's had 10 years since transplant. Those are far and few between. So the norm is continuous therapy, ongoing, even in low doses. Depth of response is very, very, very important. A deeper response is better. A lot of times, especially in the community, I don't say that community physicians don't do a good job, they do a great job, because I can't go from breast cancer to prostate cancer to lung cancer to myeloma. That's not my expertise. I can only focus on one thing. So if the thought is, hey, your numbers are better, we stop, that's not the way to treat myeloma. We want the numbers better, we want the numbers to keep going down and then stay there. Side effect profile management. I'm not going to talk about that because I think both Tim and Dr. Atchison have shared with you. Managing the dose and getting to the right dose where the treatment and the side effects can be managed, that's extremely important because that's the only way we can stay on treatment. We know that myeloma clones evolve. Myeloma evolves. The importance is that we need combinations. One drug doesn't do it because the disease becomes very quickly resistant. Also, we know that once a resistance develops to a drug, that doesn't mean that the drug is permanently gone. We can sometimes bring that drug back down the road. And we know that sometimes even minor resistance is important, so we are trying to do a lot of studies to understand why myeloma becomes resistant to certain drugs and how we can overcome that. Okay, this is a lot of information. I'm not going to go over this in detail because reading every word would take probably the rest of the day. But these are the 5 drugs that have been around forever and ever: thalidomide, lenalidomide, pomalidomide, bortezomib, and carfilzomib. But the idea is that one size does not fit all. We take into account a lot of characteristics. How does the drug work? It's oral or IV. What are the side effects? And that helps choose the right drug for the right patient. And then these are the newer 3, which are no longer that new. They are still 4 or 5 years ago, is when they came up, was ixazomib, dara, and elo, or implicity. Again, picking up characteristics and deciding what fits who at what time. But I think it's an important discussion. Every single patient and caregiver should ask that question: is this the right treatment for me, and why? Are there other options? How can we decide? Okay, so as I said, individualized treatment approach. I'm going to talk a little bit about clinical trials, and this is what we didn't talk about last year, and I think there were quite a few questions about clinical trials. Some of you have been part of clinical trial, and thanks a lot for doing that. That's how the field moves forward. But I'm going to touch upon a few things. There are lots of terms that are confusing about clinical trials. We know that on average it takes about 10 years and close to somewhere about $2.5 billion to get one drug to market. That's the amount and time that goes into on average. Only 1 out of every 10,000 molecules that starts its journey, or we think may make its journey, only 1 out of 10,000 drugs makes it to market. We think it'll be a momentous year for myeloma again this year in 2020, because we're hoping that there will be a CAR-T approval. We're hoping that there will be an antibody drug conjugate approval. We're hoping that hopefully daratumumab will come as a shot. We're also hoping that officially we'll be able to maybe change some of the labels. So it'll be probably a very important year, just like 2015 when 3 drugs got approved within 8 days. But it's important to know that unless clinical trials happen, we don't get there. So they are essential. Not all of them are randomized, meaning you will not always get a placebo or a sugar pill. Majority of those trials are not randomized, and even within randomized, majority of the trials do not use a placebo. There are different phases. We'll briefly talk about that. They're always voluntary. If you don't want to be on a clinical trial, nobody can twist your arm. And if you decide to go on a clinical trial and then change your mind, you can always come off. They're not for free. You don't get paid to be on a clinical trial because that'd be coaxing you to be on it. But the idea is that when somebody goes on clinical trial, part of their care, which they would have gotten anyways, goes through their insurance. And if there is something that is going for the trial, that goes through the research. But you can always withdraw consent. I'm not going to go over this again. As I said, you guys will have these slides if you want. Please provide your email and we'll send slides to you as a PDF. But there are preclinical testing in the lab, which a lot of it Dr. Shanahan does in the lab over here, or he runs the lab for myeloma at Mayo Clinic. We do a lot of clinical trials, phase 1, phase 2, phase 3, phase 4. Phase 1 is where we're just trying the safety. Phase 2 is when we are seeing the side effects and also the benefit. Phase 3 is when we are actually comparing it to the current standard of care. And phase 4 is when the drug is already approved. The only way that placebo or sugar pill comes is if there is no current standard today, then you're allowed to compare against nothing, because there is nothing that is proven. That is the only setting in myeloma that doesn't happen, because there is a standard of care. And then the data is analyzed, the FDA gets it, and the drug hopefully gets approved. But as I said, out of about 5,000 to 10,000 compounds, one drug gets FDA approved. So there are lots of barriers to clinical trials. Are the trials available? Do we pre-screen patients? Is a patient eligible? They are strict. They will have a lot of criteria. You have a hemoglobin of 9.99, and if the study says you have to have a hemoglobin of 10, we cannot fudge it. You have to have a hemoglobin of 10 or you can't get in. So it's very tightly controlled. Is a patient asked to enroll and even provided the support for that? Well, do we educate the patients? We do, or at least I do. We spend a lot of time. We have a lot of research staff sitting at the back over here. That's their job. They hate us for enrolling so many patients on trials, but it's important. And then, do the patients finally enroll or not? A lot of patients do say that, hey, we've heard everything, we're not going to do it. That's fine, but at least get the information. Because of all of these things, survivals have improved. This is what's called Kaplan-Mir curves. Whenever you look at manuscripts, data, these curves show up. All of us like to show them, talk about them. Basically, what this is showing is the lowest curve. Every single bump down is when survival of somebody died. Down back in 1961 to 70, more patients used to die. 2001 to 2010, whoever's been diagnosed, they're living longer. This curve now from 2010 to 2020 is probably somewhere here, but that data will come out too. So what I would say is connect with others. Hattie very well told you, go online. Don't be afraid to ask a question. Don't be afraid to talk to others. You ask, you'll get the answer. If you don't like the answer, ask again, ask someone else. But Mayo Clinic is located in 3 different locations, which even Megna's slides showed, or what Dr. Dranka would have presented. But I think the perspective I can bring is one of the patients said it. I shared it last year. They say there are 3 Mayo Clinics. There's one that's too hot, one that's too cold, and this one which is just right. So you're at the right Mayo Clinic. And we're glad that you're here. So spend the rest of the day. I'll stop with this, and I think after I write this, we have a break. I'm happy to take a few questions if you want. I know we're heading at the break time, but if there are any questions, I'm happy to take some. Thanks. Karfan Dabaja, who joined Mayo Clinic from Moffitt. He's the director of our bone marrow transplant and cellular therapy group. He's the director of our inpatient services and is also the vice chair of practice for hematology. And I can tell you that in one sentence that CAR T-cell therapy in Mayo, Florida could not have been offered the way and the timing in which it was offered if it had not been for the instrumental work of Dr. Karfan Dabaja. So it's also a very important day for us because, as Asher mentioned, Scott, who's sitting right there at the back, who's had excellent results, but he got his CAR T-cell therapy somewhere else, and actually at Roswell where we started, all of us together. And it's also special because we also have Megan right here in the front, who's our first CAR T-cell therapy patient at Mayo Clinic in Florida for myeloma, and she's here with us today. I would say that maybe Megan, if you want to stand up for a second, and Scott, if you want to stand up for a second, I think it's giving you a different perspective of what therapy can do. I know Megan has decided to come here because she wanted to be a part of this, despite her counts and the fact that she just got out of the hospital. But it's a special day. So I'll call upon Dr. Karfan to talk about CAR T-cell therapy. There are lots of questions. He's going to talk about CAR T-cell therapy for heme malignancies, and then maybe I'll talk a little bit about it for myeloma. But Dr. Karfan.
Thank you very much, Dr. Elawadi, for this kind introduction. And first and foremost, I'd like to thank each and every one of you for making time to be here today. Also, special thanks to Dr. Meghna Elawadi, who actually was instrumental in making this program possible, and all the team who work with her relentlessly. So the task before me today is actually to try to provide the framework into what made these therapies possible, and then I will have Dr. Elawadi focus specifically on multiple myeloma. So the way I outline this presentation is I would like to first start with the CAR T-cell therapy development. What are the current indications that are approved by the FDA, and particularly for B-cell acute lymphoblastic leukemia, and also for relapsed refractory large B-cell lymphoma. Then I'm going to touch briefly on CAR T-cell therapy clinical trials that are ongoing with extremely promising results in chronic lymphocytic leukemia, for which we anticipate approval of these drugs or these products. We will be having a CAR T-cell therapy for acute myeloid leukemia opening soon, and we are one of very few centers nationwide who have been selected for this type of study. Dr. Elawadi will focus on the myeloma CAR T component, and then I'm going to just touch briefly on toxicities and finally close with some conclusions. So immunotherapy, the cure is inside us, and as Dr. Shannon Khan alluded earlier, every single second of our day, our immune system is actively working to prevent or limit infections by recognizing, destroying foreign antigens which are expressed in either bacteria, viruses, and fungus, and so on and so forth. But also our immune system can also recognize, interact, and destroy cancer cells. Now, cancer cells are smart, and what they have done, they have developed mechanisms, what we call immune escape, and that's kind of a simplistic way of summarizing them, but they have learned how to avoid their destruction by the immune cells. Finally, this science called Immuno Oncology, it really focuses on finding ways of unleashing the power of our immune system using our own cells, whether T lymphocyte or what we call NK or natural killer cells, to treat and prevent cancer from development. I think if one is to look backward 50 years, turning the clock to 1970 onwards, probably the biggest revolution that made all of this possible started in the 1990s with the development of monoclonal antibodies. And there is not probably a single disease that we treat nowadays in terms of cancers that does not include a monoclonal antibody. So, for instance, for lymphomas, rituximab has become a backbone for B-cell lymphomas. Dr. Roy earlier and Dr. Shannon Khan mentioned daratumumab or Darzalex, and you can see that this is certainly one of the antibodies here, trastuzumab for breast cancer, and so certainly this revolutionized the treatment of various neoplastic disorders, whether it's lung cancer, breast cancer, colon cancer, lymphomas, and myeloma. And more importantly, provided a platform that was needed to allow development of CAR T-cell therapy. So CAR T-cell therapy stands for chimeric antigen receptor T-cell therapy, and it's really a form of re-engineering the immune system by actually re-engineering the T lymphocytes to specifically target the intended cancer cell. So if you think about it, it's almost like teaching the cell to go and find that particular cancer cell and get rid of it. Our 3 campuses are actually certified to prescribe any of the commercial available CAR T programs, whether Minnesota, Arizona, or Jacksonville. So what is entailed here? So some of you mentioned earlier bone marrow transplantation. The process of removal of the T cells is very similar to what we do in terms of stem cell collection. Now, when we collect stem cells for a bone marrow, we are focusing on the stem cells of what we call CD34 cells. Here for CAR T cell therapy, we are focusing specifically on lymphocytes. So we want to collect the lymphocytes, and then these cells are generally manufactured off-site. The process takes some time, between 2 to 5 weeks, to get the cells back. The cells are actually then sent back to Mayo. We prepare the patient by providing something called lymphodepleting chemotherapy, and the purpose here is not to necessarily target the myeloma or the lymphoma or so on. The purpose here is to open the space by removing some of the lymphocytes which really haven't performed well in terms of protecting and treating the cancer, and trying to bring back those cells to repopulate our bodies, and actually they will expand, go after the cancer cells and kill them. So the process is, from the logistical standpoint, is complex. Not every cancer center in the country can perform this type of procedures. You have to go through a rigorous certification process in order to be able to prescribe this type of therapies. There are 2 indications. I know that the forum is for myeloma. So far, we don't have any CAR T approved for myeloma. These products are still undergoing clinical trials. We anticipate that so far results being so amazing that an approval will be issued hopefully this year. But we have indications for B-cell acute lymphoblastic leukemia, for patients who are up to 25 years of age, and this is the name of the product, Leclusel. And then for patients with relapsed or refractory large B-cell lymphoma after failing 2 or more lines of therapy, we do have 2 products that are approved. One is axicabtagene ciloleucel, which was approved in October of 2017, and in May of 2018, tisagen leclusel was approved. And you can see the different subtypes of the diseases for which these products are approved. So let's start with B-cell ALL, or B-cell acute lymphoblastic leukemia. And this is a story that many years ago actually captivated the attention of many of us. This is a young girl at the time. Her name is Emily Whitehead, and this patient has actually failed all types of treatment that were available under the sun. She failed an allogeneic transplant, and for patients who fail an allogeneic transplant for B-cell acute lymphoblastic leukemia, typically the life expectancy is measured in weeks. So this patient was among the first who received the treatment at the University of Pennsylvania, Children's Hospital of Pennsylvania, and actually this is that patient 5 years later, and she has continued to be in remission for many, many years. So wow. We are talking about almost 12 years of remission now, with the last update in this case. So these treatments certainly do work. This is the study that led to the approval. 107 patients were screened, 92 were enrolled, but only 75 received the treatment. And the reason for that is sometimes patients do progress, do get infections, or the disease just simply progress and they cannot receive the treatment. So as you can see, somewhere around 20 to 25% will not even make it to the procedure. So what is important here is timeliness. Referrals have to be timely, because the more the disease is kept unchecked, the more difficult will be for these treatments to, first for the patients to reach the treatment, and second for the treatment to be effective. So in this case, 46 patients, or around 61% of the patients, had failed an allogeneic transplant. So to give you some background for this particular disease, if a patient were to fail an allogeneic transplant and be treated with any other type of therapy short of a CAR T, the probability of surviving that year is less than 5%. So certainly this patient population, we're looking at them 12 months later, and you can see that the survival around 12 months later was 76%. So we have been able to improve the prognosis for B-cell acute lymphoblastic leukemia from less than 5% life expectancy if those patients have failed an allogeneic transplant. Now, not all of them do receive the allogeneic transplant, obviously, but those who did, the probability of survival goes from less than 10% to up to 76% for 1 year. So the question always comes, well, what about later follow-ups? These are just brand new therapies. And this is the last follow-up at 18 months, the responses are still holding up. So certainly these treatments work. 70% are still alive, and 66% of those have not had the leukemia relapsing. So certainly impressive data by any criteria. Now, let's go briefly into large cell lymphoma. This is the name of the study that led to the approval of this drug, axicabtagene ciloleucel, for patients with relapsed large cell lymphoma. And you can see that before CAR T-cell therapy, if we were to offer any treatment for these patients, the probability of achieving a complete remission for a patient who had failed 2 or more lines of therapy for lymphomas was around 7%, at least based on 2 studies. With CAR T-cell therapy, that number goes up to somewhere between 49 up to 70% or so. So we're increasing the remission rates on these cases, complete remission rates, from 7% up to 70% at the highest, so around 7 to 8 times improvement in complete remission rates, and also are translating into improved survival. So briefly, a patient based on this study, which is a multi-center retrospective data analysis called the SCHOLAR study, which looks at the question, what would have been the survival of a patient who failed 2 lines of therapy for lymphoma before CAR T-cell therapy was approved? And the answer was 12%. Now, what is the survival with CAR T-cell therapy? And the number is 50%. So we have been able to improve survival by at least 4-fold, and that certainly has translated into at least 73% reduction in the risk of death for this type of lymphomas. This is an updated analysis that was presented last year in Orlando for this initial study, and we can see that the survival at 2 years, companies which sponsored the study, Kite Pharmaceuticals, reported 51% 2-year survival or 24-month survival. At 3 years, the number is still holding up around that range, around 47%. So it is probably unlikely or have a very low probability that if a patient is able to keep a remission for 2 years, the likelihood of progressing after that with CAR T-cell therapy is extremely low, in perhaps single digits. So this is certainly a breakthrough in terms of the treatment for this type of lymphoma. This is a second product which also shows equally exciting results, showing 18-month survival of over 40% or so. So these are products that are very effective, as I mentioned. It's not available for universal applicability because some of the small clinic practices cannot handle this logistical complexity. But certainly it's important to be aware of these treatments and to try to access this type of treatment in a timely manner so that the chances of success are increased. Other diseases like CLL, again, making a note that this is not approved yet for CLL, but there is certainly encouraging data. And similar to myeloma, we have also in CLL extremely bad disease players like 17p deletion or p53 mutation, or a complex karyotype, or relapsing after multiple lines of therapy. And in this particular study, which again is showing promising results, these patients were treated, and this is not where we are really being selective on trying to choose the best, youngest, or more fit. These are patients where the median age for the disease is actually 66 years, and in the study, the median age was indeed 66 years. So certainly patients who are of that particular age group are being treated without being selected in terms of course or performing any bias in terms of selecting these patients. And these patients actually were randomized to receive either a dose level 1 or a dose level 2. Again, this table just summarizes how aggressive disease they had. Almost half of them have, or over half of them actually did have 17p deletion. As you can see here, p53 mutation of 61%. Almost all the patients have failed the most effective therapies, whether ibrutinib and or venetoclax. And we can see that despite all of these adverse risk factors, these patients had impressive response rate. When you look at all the cases, regardless of the dosing, 82% of them were able to show objective responses, of which 46% were actually complete remission. So impressive results by all means, never seen with anything before CAR T-cell therapy. Challenges, again, some of the patients in the audience have gone through this procedure. So one of them is what we call cytokine release syndrome. It can affect any single organ in the body. Typically, it could be a grade 1, which manifests as fever. If the fever does not respond to normal Tylenol or other type of supportive therapies, then we will proceed with a treatment called tocilizumab. But these patients, if not treated promptly, they can also develop serious side effects where we can have sometimes cardiovascular compromise or renal failure or respiratory dysfunction and so on and so forth. In terms of the onset, typically happens in the first 1 to 2 days. For some of the products for myeloma, it may vary slightly. In some cases happens within 24 hours, as it was one of the cases we had. And it could certainly can happen within even as late as 10 days from infusion. If left unchecked, these cases can go into multi-organ dysfunction and what we call fulminant hemophagocytic lymphohistiocytosis, or short known as HLH. In terms of neurotoxicity, that's a little bit more tricky and tends to have 2 phases. The first phase that can happen typically within day 0 to day 5. It can happen concurrently with the cytokine release syndrome, or a more serious one, which is a phase 2, that can happen usually after day 5 onwards, and by that time the CRS may have subsided. So the good news is that these are all treatable, and most of the studies have shown that the probability of actually having a serious toxicity that can lead to the death from this type of treatment has been less than 2%. So the conclusions I'm going to then pass on the presentation to Dr. El-Awady is that this truly represents a true success in the pursuit of personalized cancer care. This is using the patient's own cells, manufacturing them, re-engineering them, and actually we have shared this morning that it can actually alter favorably the natural history of diseases like B-cell lymphomas and B-cell acute lymphoblastic leukemia. Very promising results, as I showed you with chronic lymphocytic leukemia. For CAR-Ts in myeloma, I would certainly leave that part to my colleague, Dr. El-Awady. I'm just saying that many times we read a lot of things when we Google information, but certainly it's important to seek the professional information and not try to make judgment based on what you read on the internet. Sometimes, and many times, what you read is true, but sometimes you're just looking at one particular case where the experience may not have been that great, or one case where the experience was excellent. So it's always important to seek professional opinion when trying to pursue this type of therapies. Important is to diagnose these cases earlier and actually to intervene in a timely manner. So I will leave the rest of the presentation to Dr. El-Awady, who is actually leading our multiple myeloma CAR-T therapy efforts at Mayo Clinic and have been extremely active. In fact, we have several studies that are opening for treatment of myeloma at different stages of the disease, hoping to open a study soon that will look at myeloma treatments earlier rather than on the later phases of the disease. Dr. El-Awady.
Thanks, Dr. Kaplan. I really appreciate this, and I again want to point out, like I said, the timeline for CAR-T at Mayo, Florida was probably sped up by at least a good 1 year because of his efforts and expertise. So now I know we're running behind, and this is when we were supposed to eat lunch, so there will be lunch, I promise. But I'm going to quickly go over a few things which are more myeloma pertinent. So I'll go back and kind of tie a few things that Dr. Shanakan said and what Dr. Karfan said and try to make some sense, because still, I completely get it. Not everybody in the audience is at the point that CAR T is anything more than a buzzword, or what is it? So basically what I wanted to say over here was that there are all these markers, all these things that are jutting out of a cell, of the plasma cell in this case. And the goal is to create treatments that can go against that particular marker. The two markers that are extremely important right now for myeloma are the two marked here, CD38 and BCMA. Now the CD38, or cluster differentiation 38, marker 38, this is where the daratumumab works, for example, and we're hoping there will be a second drug in that family this year approved for that. The BCMA, which is the B cell maturation antigen, which is universally present on all myeloma cells, is what majority of the CAR T cells in myeloma today are targeting. You've heard about drugs BB2121, BB21217, JCAR, LCAR, MCAR. These are all numbers or letters associated with different CAR T cells. All of them almost are targeting the BCMA. There are others, and I'll touch upon them. Why this is important for you to know is because as of right now, the clinical trials say you can have only one BCMA targeted therapy. If you go to an antibody targeting BCMA, or a CAR T targeting BCMA, or a bispecific antibody targeting BCMA, or a what's called an ADC, and I'll touch upon that, antibody drug conjugate targeting BCMA, once you get one of them, you cannot go on to any other clinical trial or for that marker, for BCMA. So that is the tricky part where not everybody may be a candidate for CAR T. Dr. Karfan laid out side effect profile, right? CRS, neurotoxicity. Some people can have a lot of side effects. When you look at Scott and Megan over here and you're thinking, well, everything's fine, everything's great. These guys look great, but they had their own share of some side effects, and there are others who could have had worse. So the idea to understand is that when we talk about CAR T or BiTE or ADC or whatever, it is talking about treatment against a target, and these are all different mechanisms to try and target that particular thing. So over here, what I've kind of pointed out is, let's take that BCMA, the B cell maturation antigen, and we could develop a CAR T cell therapy against it. We could develop a BiTE or a bispecific antibody against BCMA. We could develop an antibody drug conjugate or ADC against BCMA. These are all different ways of targeting that BCMA. So as I said, the CAR T cell targets that are being studied or worked upon right now in myeloma, BCMA makes up approximately a good 70 to 80% of CAR T cells that are out there in clinical trials. So which means that 70 to 80% CAR T cells in myeloma are targeting BCMA. But there are also CAR T cells against CD38, which is a marker, CD19, which is a different marker, a combined CAR T with two markers, BCMA and CD19, SLAM F7, which Amplicity is against, well, there's a CAR T in development against that, CD138. CD138 is almost a universal marker for myeloma, well, there is a CAR T against that that is being developed. And we talked about light chains, there is a CAR T in development for light chains. And on top of that, there is a layer of complication because not only are the autologous or the self-CAR Ts being worked on, there are also allogeneic. Like in transplant, Dr. Roy talked about self-stem cells or donor stem cells. Allogeneic CAR Ts are also being developed, so you could literally get off-the-shelf CAR T cells, and it is not that a person has to go through their own T cells being manufactured, so that lag period of 2 to 5 weeks could potentially be cut short. This is where the confusion comes to all of your minds, because what you think is, well, there's CAR T, I want CAR T. But that's where the complication comes about, well, have you had a prior therapy against that target for which we have a CAR T or not? Do you have access to an institution which has CAR T cell trials or not? What are the logistics? Do you fit into those trials? Have you had enough treatment? So we have one patient over here, we really want her to get to CAR T, but she had not had treatment with daratumumab. And a CAR T cell trial right now will not allow you to go on unless you have failed a proteasome inhibitor, which is bortezomib, Velcade, or Kyprolis. If you have failed an IMiD like Revlimid or POM, or if you have failed the daratumumab. You have to fail all three to get onto any CAR T cell trial right now.
Wow.
And we feel that when this year, hopefully we will get the commercially approved one of them, that will most likely have it in its label. We don't know what the FDA writes, but we are expecting the FDA to say, well, you gotta fail those 3 drugs first, and only then you get a CAR T.
Wow.
Now we're hoping that very soon we'll open another clinical trial in Mayo, Florida, where we'll be offering CAR T frontline therapy to high-risk myeloma patients. So you have a high-risk disease, you get your induction, you get your control, you get your CAR T right there. You don't have to wait for later, because we know early on is when we get the best chance. So that is where the confusion is coming in everybody's mind, because you hear CAR T, but you don't know that there are so many layers or so many differences in it. So this slide is just trying an attempt to tell you about why are these different. These are all, so these 5 that are listed over here, the genetic structure of what an anti-BCMA chimeric antigen receptor looks like. These are blocks which don't make much sense, but basically some of them are protein areas or linkers that will make this molecule active against the BCMA of a plasma cell. Now when BB2121 is used, you can see that they added a different connection somewhere. Everything else is almost the same. Then BB2121-7 came, and that added a separate moiety or a separate protein called PI3 kinase inhibitor. So it's actually adding to the activity of the CAR. And this MCAR has a different kind of linker, so not this linker which BB has, this has a different linker. Or LCAR, which is another drug which has actually shown a lot of benefit and is in a lot of clinical trials. Unfortunately, we don't have it in Florida, but Arizona and Rochester have this. Well, they have another different kind of a linker, and then these 2 blocks are together. This blue block is missing. So this is a chemical way of manipulating the drug, adding pieces or taking off pieces. Well, for one, because that provides that company with the patent for that particular drug. But 2, importantly, that also kind of restructures the benefit and, importantly, the toxicity. So, for example, I would take an example, and I know Megan's here, and again, like I said, this is a landmark moment for us, because we have our first myeloma CAR T patient who has been treated and is here and is hopefully doing well. Well, she was doing fine, but when we got the treatment, the company or the person, the company representative said, well, we expect a fever within 1 to 3 hours. And that was right. 3 hours later, she had a fever. And then we monitored, and then we did whatever we did. And then the next thing was, okay, well, everything's fine, maybe she should go home. But we also knew that neurotoxicity risk was there between the 10 to 14 day mark. So we said, nope, we're going to monitor, we're going to keep her here. Now I'm pretty sure Scott got a different CAR T, and the side effect profile of that CAR T would be different from this. And some will bring in toxicity sooner, some will bring in toxicity later, some say later is better. So that will be the defining factor of all these CAR T cells, of what is safe, what is effective. And as Dr. Karfan has very nicely brought up, well, there will be, unfortunately, some patients who will not stay in that state of remission. but there will be a lot who will stay in remission and who will have that good long-term outcome. So getting access to these clinical trials is important, and this is why there are so many of these molecules, because as the big companies are there, all those companies have their own proprietary twist to it. Over here in Florida, in Jacksonville, and my wife brought up the talk about the first-in-human clinical trials. We have a lot of them going on. For example, clinical trials that are targeting BCMA with a CAR-T, with a BiTE antibody or a bispecific antibody, or with a monoclonal antibody, and we have a lot of patients on all of these. Some of them are here. You can probably talk to each other. With CD38, we have, again, a CAR-T. Unfortunately, this is on hold right now, but hopefully will start soon. Dr. Shanahan mentioned this ADC, or an antibody-drug conjugate, where the antibody is against the target, but it brings with it a toxic payload to kill the cells. This TAC-169, we are one of only 2 centers in the country who have access to this drug. And we're excited about this because these are novel mechanisms. Again, a bispecific antibody against CD38. BCL2 in a pathway that Dr. Shanahan didn't touch upon, but our lab over here has done a lot of work. Some of you have probably already gone through this particular drug, which has a very specific activity against translocation 11-14 mutation. So that's our job, to try and pick out the clinical trials and bring out to you and say, hey, these are the clinical trials available. We think this may be the best option. We have one of our patients here. She walked out of the clinic appointment with 3 different clinical trial consents. And I said, well, these are the 3 studies available for you. And in my opinion, this would be the best, but I want you to know about all of them. We have a radioisotope that I know Gary has talked to me about for several times, that, hey, we should probably highlight this. And we had a very big presentation at the American Society of Hematology meeting in December, where I presented data on this, and many, many more in the works. So I guess the idea is that we are in a spot where we have more optimism than not, and we have so many more options that we can use for bringing to patients with myeloma. I'll let you go out for lunch, and again remind that we are here, ask questions, and please, another reminder, our volunteers are going to go around collecting those surveys. If you guys have done those patient surveys, please leave on your tables, they'll collect. And then they're anonymous, but we'll try to see how many patients registered and how many